Hi guys, Dr. Rajarathna here. Yet another episode of this Let's Cram It. First question, we talk about steatoria and some small intestinal biopsy findings. So this is about A-beta lipoproteinemia. So what is A-beta lipoproteinemia? There is no ApoB lipoprotein in the body because of a mutation in a gene called MTTP. What is MTTP? Microsomal triglyceride transfer protein. So this is essential for ApoB lipoprotein formation and secretion. So we don't have VLDL, LDL and chylomicrons in the body. So what will happen? The fat will not be absorbed from the gut. It will all be passed in the stools. So steatoria, fat soluble vitamin deficiency, and you will have acanthocytes in the blood. Now makes sense. We are talking about Basin-Consweig syndrome. So what will be your eye finding? Retinitis pigmentosa. Okay, and this syndrome is autosomal recessive in inheritance because they love inheritance wala questions. Question number 2 about Shillings test. It is for assessing vitamin B12 absorption or malabsorption. So how is it done? Quickly. So there is a radio labeled cobalamin which is given orally, and 1 hour later there is intramuscular B12 also given, and then we do a 24-hour urine collection. So when is it considered abnormal? When less than 10% of the administered vitamin B12 is excreted, it is considered abnormal. So what are the abnormal conditions or abnormal Shillings test wala conditions? So we have achlorhydria, we have pernicious anemia, we have bacterial overgrowth syndrome, chronic pancreatitis. So remember especially A, B, C. Anemia, pernicious anemia, bacterial overgrowth syndrome, C, chronic pancreatitis. And also important ileal diseases, because all these areas are important for vitamin B12 absorption. Now question number 3, gastric adenocarcinoma risk factors. Now we all know H. pylori is very important as a risk factor by causing chronic atrophic gastritis, and also pernicious anemia by causing chronic atrophic gastritis. Any other organism? Yes, Epstein-Barr virus also can cause gastric adenocarcinomas. Now intestinal metaplasia 2 and 3 can cause, but not type 2. Menetrius disease, yes. Adenomatous gastric polyps, again yes. Question number 4, Barrett's esophagus. What is Barrett's esophagus? The squamous epithelium of distal esophagus is replaced by columnar. So it is columnar metaplasia, not squamous metaplasia. So there is a risk of esophageal adenocarcinoma. Now option C, it's a salmon pink appearance but above the gastric esophageal junction. Now option D, it affects distal esophagus, not proximal esophagus. Question number 5, Zenkers diverticulum, another high yield topic. It's an outpouching of the pharynx through Killian's dehiscence. What is Killian's dehiscence? It's a weak part of which muscle? Again important, inferior constrictor muscle. Now option B is the answer. Why? Because Zenkers is a false diverticulum. It does not contain all the layers of pharynx. It only contains mucosa and submucosa. So 5 questions, quick fix 5er. You've listened to it, repeat.